We're delighted to have on board today for the symposium and webinar Professor Martin Sullivan. Professor Sullivan is an orthopaedic foot and ankle surgeon working predominantly at St Vincent's Clinic in Sydney. He trained in the US and the fellowship in 1994 and has really been responsible for some innovation in a number of ways. He's developed an endoscopic technique for the resection of Haglund's deformity back in 1996, and has trained multiple fellows from across the world, including the US, England, Philippines, Australia, and more. He's also presented widely internationally and has a strong interest in research with published papers on wide topics, including cartilage repair, some posterior impingement work, and some incidents in DVT, including some of the cartilage work as well. He's been involved in the surgical management of elite athletes for many parts of the globe. And a large part of his practice has really been the management of patients who have failed to progress after ankle or sprain injuries. And this, as a consequence, has led to his extensive experience in dealing with articular cartilage damage in the ankle over the last 25 years. And really, Martin has been a pioneer of the use of ACI and MACI within the ankle area. And I've been fortunate enough to have worked with Martin right at the very beginning of the introduction of ACI into Australia, and his work in the ankle and results has really been a delight and a pleasure for us to be involved in. And so without further ado, I'd like to invite Professor Martin Sullivan to give him some insights on cartilage repair within his practice. Thanks, Martin.
Thank you, Paul. What I thought I'd do just tonight for the people who's sharing the information is just take you through the journey that I've been on over the last 25 years involving cartilage transplants. As you know, most of the patients that we see with articular cartilage damage in the ankle undergo arthroscopic surgery. What we tend to do is identify the lesion, probe the lesion. We would remove any unstable articular cartilage arthroscopically. And often we'll see patients who have large osteochondral defects as a result, particularly ankle sprain type injuries, and certainly in the sporting arena. Early on, the literature in 2002, 1999, a number of papers reported that the majority of isolated talar dome lesions respond well to debridement or microfracture using this arthroscopic technique. In the ankle, we know that lesion size now is extremely important. And if you look at, if I just go back one, so we size the lesion arthroscopically, you can see there, and some of these lesions can be quite large that we see in clinical practice. And it's not uncommon to see lesions as large as 2 centimeters. The average size osteochondral lesion in the ankle is usually around 3 to 4 millimeters. So we know that large lesions, which by definition are greater than 1 centimeter in the ankle, may not respond well to debridement or microfracture. And the outcome is less reliable after these first-line treatment options. For patients who have a lesion in the talar dome, then which is greater than 1 centimeter, then there's really only about a 45% chance of getting any successful outcomes with arthroscopic treatment using either debridement or microfracture. If we look back in 1994, to give you an idea of the time frame of what has happened, the World Wide Web started, but I came back from the United States in 1994, and after being in practice for less than 18 months, found on the internet, and in those days was just a single telephone line modem, web page by an unknown surgeon at the time from Hungary called Laszlo Hangodi. And he had on his web page this technique called Mosaicplasty or oats. So I actually managed to contact him back in 1996, and he came out to Sydney, and I met with him over a coffee, and we talked about his new technique. So in 1996, obviously most of his early work referred to the knee, but I started to use the Mosaicplasty technique or oats procedures for talar dome lesions that had failed microfracture. And I think it's important to point out early in this talk that the idea of ACI, MACI, or these what we call secondary or tertiary procedures, in my practice, I only use these for patients who have failed arthroscopic debridement. It's not a first-line surgery in my practice and never has been. So if you look at Laszlo Hangoti, some of you may have met him in the past or heard him speak. I mean, in Hungary now, he's recently received this award for Mosaicplasty, which has in the past been the most used cartilage surface restoration procedure worldwide. So from 1996 to 2002, I used the Mosaicplasty technique or OATS for these medial talar dome lesions, large lesions that hadn't responded to arthroscopic debridement or microfracture. I used to harvest the plugs from the knee, from the medial femoral condyle. And in the ankle, to do this procedure, you have to do a medial malleolar osteotomy. And that was something that I was never really entirely comfortable with, in that, to me, the idea of creating this large osteochondral fracture of the tibia to deal with a greater than 1 centimeter lesion in the talus just didn't really sit well with me, and I was constantly looking for alternatives. Having said that, here you can see just a photo where after you do the osteotomy, you have to internally fix the medial malleolar osteotomy, and this can create problems, particularly in terms of imaging of the grafts later on. May involve further surgery to remove those screws, but the medial malleolar osteotomy has some morbidity associated with it. But in my experience, the Mosaicplasty or OATS procedure was a very reliable procedure. Here you can see a previous OATS procedure on the left. I'm not sure if my arrow is working here, but the graph looks fine. There's an MRI of a previous lateral talar dome procedure where Mosaicplasty or OATS was carried out. But there are problems with it. Unfortunately, where the defects in the talar dome are often not perfectly round, and so you can't completely fill the defects with that procedure. And I have had patients referred to me. This patient, you can see, has had a Mosaicplasty, and then just posterior to the Mosaicplasty, there's a defect where the arrow's pointing to. And patients have been referred to me where they have continued pain from those areas that haven't been covered, and I've actually done MACI in covered those areas successfully. So from 2002 onwards, having said that I was not entirely happy with having to do an osteotomy and going to someone's knee and taking plugs out of their medial femoral condyle to deal with the problem in their ankle, Mercy Tissue Engineering in Melbourne ran a course, was predominantly for knee surgeons. And I did that course. So I started to use the ACI or first generation technique for salvage of these large defects in the talus. Now, this technique does require a medial malleolar osteotomy. And for those of you who are not familiar with it or haven't done it, usually what happens is we harvest a periosteal patch, and we inject the chondrocytes into the defect, and then we have to suture the periosteal patch over the defect to keep the cells from leaking. Unfortunately, the ankle talar dome, the cartilage thickness is only approximately about 1 millimeter. So in the knee, the cartilage thickness is about 4. And so even with the medial malleolar osteotomy, I often found it was extremely difficult to get many sutures to hold the periosteal patch in place. So I wasn't entirely happy with that, and again started to try and look for an alternative management of these large lesions in the talar dome. In 2004, I was asked to talk just in a general sense about the talar dome defects and management to the Australasian Tissue Bank meeting. And then in 2004, I started to do a MACI procedure. And the reason I did that was because I was able to do it without doing a medial malleolar osteotomy. So MACI, what it involves is we harvest these chondrocytes. They're grown in culture. We seed them in this collagen bilayer membrane, and then we reimplant the membrane into the defect. And here you see the arrow pointing to this collagen membrane, porcine type 1, type 3 collagen, which is seeded with the chondrocytes. So that technique of doing MACI in the ankle without a medial osteotomy was presented in Boston at the summer meeting, the AOFAS, by my previous fellow, Eric Gieser. And here you see this photo is actually a slide of the membrane covering the defect. This slide, as I've noticed, has made its way all around the world. I've seen on a various VUMEDI talks, but this is a patient of mine, and you can see how the defect is entirely covered by the membrane. And we secure that membrane with a fibrin, usually using fibrin tissue glue. There were a number of papers in 2005 in the British Journal of Bone and Joint Surgery highlighting that harvesting plugs from the knee is associated with certain morbidity. And then a paper in 2005 in Cartilage discussed using the detached osteochondral fragment as a source of cells in the ankle joint. Having come across these two papers, not entirely happy with having to go to someone's knee to deal with a problem in the ankle, I started to harvest chondrocytes from the ankle in 2005, using that detached articular cartilage fragment on the talar dome. So here you can see, take those fragments, and instead of going to someone's knee, and there are people around the world that still do that, and the consensus is that that's possible. But in my practice, what I started to do in 2005 was start to use the damaged articular cartilage in the talar dome as a source of chondrocytes. So we can harvest this at the initial arthroscopic debridement procedure, or if a patient hasn't had any tissue harvested and they go on to have a large defect which has failed first-line treatments, then we can go back in and take some articular cartilage from the periphery of the lesion. So in my practice, obtaining samples to do harvesting for the lab in Perth is not necessary. And here you see, again, the lesion has been debrided, all the unstable articular cartilage has been removed, and here I am handing it to the nurse, and that's usually passed on, and then it's sent to the lab in Perth. Once the tissue was sent to Perth, the initial weight and number of chondrocytes are measured. The chondrocytes are isolated and expanded over a period of 4 to 6 weeks. And prior to freezing the cells, the cell viability was calculated by basically counting the percentage of viable cells, and this was recorded. The lab in Perth, I must point out, by way, I've not received any financial grants, or I'm not I've never received any financial money from the lab, and I actually went to see the lab at an AOA meeting only 2 years ago. I'd never actually been to the lab, so I made a point to go and visit it. And any of you on the East Coast, if you get a chance, it's worth a visit. So here was I went to the lab. So what happened was the lab records all this information, and we had a database over a period of years. We used to send this tissue off, and one of my fellows, Chris Krulin, who's now in the university at Sacramento with Eric Gieser, he actually went to the company, and all the data was looked at, and he actually published a paper in Foot and Ankle of all our patients, and looked at the actual data in terms of cell viability. He actually won an award at the International Sports Medicine Fellows Conference in Carlsbad in 2012 for this paper. So essentially there were 151 patients, and he had all the data, and he showed that in 85% of cases, the cell viability was exceeded in 123 out of those 151 patients. So this formed the basis of a case of where we had a professional footballer, and here you can see he's got a complete diastasis. There's the talus is on the medial side, fibula, and there's an osteochondral fragment sitting in the gutter between the fibula and the talus. And we used that, basically that fragment, and reimplanted that using fibrin tissue glue, because we knew that the cells are viable, and that we went on to publish that as a case report as a professional rugby player with a successful return to sport within 6 months. So in 2006, I was asked to present the initial MACI work in the ankle at the International Cartilage Research Society in San Diego, and then at the American Academy in 2007. You can see, if you look back there's the defect. This is the arthrotomy, where you can identify, you don't need to do a median malleolar osteotomy. You can see the lesion, we can get access to it. So in 2009, it's worth pointing out the initial 2-year results of MACI with a median malleolar osteotomy were published in Foot and Ankle by the group from Melbourne under Tim Schneider. The difference, though, we presented our results in Vancouver in the same year, and we wrote a review article in the American Academy Journal in that year. And in 2010, our initial 2-year follow-up results without a median malleolar osteotomy were published in Foot and Ankle International. Eric Gieser, who's professor at Sacramento, was my fellow, and that was published in 2010. But unlike the difference between the Melbourne group and us is, and I wasn't really aware of this until recently, that their patients, they were using MACI as a first-line treatment for large defects, whereas the patients that we've published and reported on average had approximately 4 procedures prior to the MACI. And so we were using MACI as a salvage, and that's something that I've always advocated, not as a primary treatment. However, it's worth pointing that the group in Melbourne did do that work, and we'll get to some of that later on. In 2011, because there was very little written on this, and obviously these patients need a rehab protocol, well, I published my postoperative rehabilitation protocol, and that was in Cartilage in 2011. So in 2014, Chris Crulin presented our 7-year follow-up for MACI in the ankle, and that was at the International Federation of Foot and Ankle Society meeting in Chicago. And he published those results in 2017. And I've been involved in a number of book chapters with Rick Ferkel, particularly on the rehabilitation after MACI treatment in the ankle. Unfortunately, most of the rehab work that was published initially all was on the knee, so we had to work from scratch to do that. In 2019, last year, Chris Crulin presented our 13-year follow-up of this group at the 50th American Foot and Ankle Society meeting in Chicago, and we published a chapter in Chapman's textbook of orthopedics. So by 2004, from 2012, to give you an idea of the volume, because again, remembering it's a salvage procedure, I performed 86 MACI cases without a medial malleolar osteotomy. As I said, they're all for salvage, and they're not basically for failed first-line treatment. At that point, around 2012, the only other group in the world that had similar numbers for MACI doing the procedure without a medial malleolar osteotomy were Giannini's group from the Rizzoli Institute in Bologna. The problem that I had was this: we both had small numbers, and how do you get the surgeons from all around the world to improve our knowledge, validate our treatment options when we can only, most of us only had small numbers over, essentially, probably in my practice, you're looking at 6 to 8 cases a year. And that all changed in 2012. John Kennedy from New York, Rick Ferkel, Nick Van Dyke, and Chris Murakowski, who's the orthopedic resident at the time, basically organized the first International Congress of Articular Cartilage Repair of the ankle in Dublin. And what they did was invite surgeons from over 40 countries who had either published on the area of cartilage repair or were known to have a particular interest in this area and had a reputation. And this was a game changer. After that meeting, it eventually led to this international consensus meeting at the University of Pittsburgh in 2017. This was the 5th meeting following on from that initial meeting in Dublin. It involved surgeons from 6 continents, 25 countries. And you can see here, this is just taken from, 15,000 emails, 95 participants, and it was 11 working groups. So they're looking at diagnosis, radiological assessment, a whole lot of groups. And obviously, these surgeons from all over the world And I was involved as the leader with Rick Ferkel based on the scaffold-based therapies. And here you can see Victor Valderrama has written extensively from Switzerland, and the group that were the delegates in our group. And this went on over 2 days. And what we were trying to do was get some consensus on various matters to do with a cartilage repair in the ankle. For the first time, Foot and Ankle International published those proceedings as a supplement in July 2018, and there were 11 papers that were published as a result of that consensus meeting that happened in Pittsburgh. The last meeting that occurred was in Dublin. Here's my previous fellow Eric Gieser there on the left, and this was in the International Congress in Cartilage Repair of the Ankle. I think it's worth pointing out in September this year, Tim Schneider's group actually followed on and published in Foot and Ankle International their average 12-year follow-up of patients with MACI, both with clinical and radiological analysis. In their group, they were 20 patients originally. They only managed to actually locate 15 of those, and they do identify that as being a problem. But it's important to point out that the average defect size in the talar dome was 2 centimeters. All of their patients had had a medial malleolar osteotomy, and 25% of them required removal of the hardware. And they considered, what they did was publish that they considered the need for an osteotomy to be a disadvantage due to the cost of 2 procedures, and there's basically more involved. However, they said it's a reliable and safe option. This is with, on average, 12-year follow-up. They had a high rate of satisfactory results with long-term effectiveness. The only difference that they reported was this was a first-line treatment option. And so there was a comment at the end regarding, comparing that to microfracture. But as I said, our experience has never been to advocate as first-line treatment. This is a patient of mine. You can see the arthrotomy scars. She's had bilateral MACI procedures. She essentially had 2 centimeter large osteochondritis dissecans type lesions. And here you can see her now. She originally was a teenager when I first met her. Here's her MRIs, average 13 years after the MACI procedure. You can see on one ankle, she had an ankle ligament reconstruction as she was unstable as well on that ankle. And there's the MRIs at 13 years follow-up. And this is her recently. She's now married. Come back again. Obviously likes wearing high heel shoes. Anyway, I thank you. This is just a photo of Mike Coughlin at a fireside chat with a dear friend of mine, also John Negreen, colleague from Sydney, at a recent meeting. But I thank you for your time. I do have one slide for Zeng if he wants to make any comments. This is a patient, a histological slide. I would not normally go and biopsy lesions for the sake of it. For some reason, there was a patient that we had to go back in, and while we were there, we took a biopsy of the edge of the lesion. It was about 13 months after a MACI. I just wanted to ask Zeng if you had any comments on the biopsy.
Well, this is typically look like a MACI graft. It has a lot of highlight-like cartilage regenerations. They integrate into the side of the MACI graft. On this side, you can still see some creak. On this side, I don't know, is this surface or that surface? This is the most, is where the superficial layer, I don't know the orientation, but in general, by the look of this nature of this cartilage, it's a good highlight-like cartilage metric. The chondrocyte itself, you can see here, is a round-shaped chondrocyte up here. Then occasionally you can see some spindle-shaped cells around here. And most of these chondrocytes is sitting in the single lacunas, and some of them is already at the stage of hypertrophic states. They do making some metric, and likely I think there's some graft collagen materials, which is normal that we see up here, integrate into the metric from the original scaffold and still maintain. Yeah.
Thank you, Professor Sullivan. That was an outstanding presentation. Really enjoyed the chronological development of your experiences, in particular the clinical insights that you delivered today. And importantly, in understanding that some of the work that you've done through the journey has influenced clinical practice. And I think that's a fantastic piece. So thanks very much for that fantastic presentation.